Hello, my name is Craig Freyer, and I'm a clinical pharmacy specialist in hematology, oncology, and stem cell transplant at the Hospital of the University of Pennsylvania in Philadelphia, Pennsylvania, the United States. And I'm going to give a brief discussion about how to perform conditioning chemotherapy prior to allogeneic stem cell transplant for patients with myelofibrosis. Many of us know that over the past decade or so, we've had a lot of developments in the field of myelofibrosis, especially in the field of JAK inhibitors for the treatment of patients' symptoms. However, the only curative option for these patients does remain allogeneic stem cell transplant. And because the age of diagnosis of myelofibrosis is oftentimes greater than 60 years of age, and these patients oftentimes have comorbidities, constitutional symptoms, significant marrow fibrosis, and also splenomegaly, transplant can be a complicated process, and it can be challenging to identify the optimal conditioning regimen for a patient if one exists. The first question we typically ask ourselves when performing transplant conditioning is whether we should give myeloablative versus reduced intensity conditioning for our patient. And unfortunately, there's no prospective randomized data to guide us in either the selection of a regimen or the selection of intensity, myeloablative versus reduced intensity. We do have some retrospective data and some non-randomized prospective data that can help us in our decision. So the first study I wish to discuss is a large retrospective EBMT study of more than 2,200 patients that was published just in 2019 that compared myeloablative versus reduced intensity conditioning in patients that were transplanted between the years 2000 and 2014. And in this study comparing the myeloablative versus reduced intensity arms, you see that at 5 years, the GVHD-free, relapse-free survival was improved with myeloablative chemotherapy at 32% compared to the reduced intensity chemotherapy at 26%, which was statistically significant. Within this, we also see a reduced incidence of relapse with the myeloablative conditioning of 2 to 3 percentage points, depending on the time point. But this trended towards significance. It did not reach statistical significance. There was a significant reduction in graft failure with myeloablative chemotherapy, which is a common concern in patients with myelofibrosis due to issues with engraftment and graft failure. However, importantly, there's no difference in overall survival at 5 years between the myeloablative and the reduced intensity groups. And unfortunately, there was no specific regimen within the myeloablative arm that showed any significant impact on overall survival compared to any other regimen. So early on, we do see that myeloablative could be helpful if, in fact, the patient can tolerate it. Subsequently, a recent publication last year in 2020 by the group at MD Anderson attempted to identify a reduced toxicity myeloablative regimen, that being myeloablative fludarabine and busulfan, and compared that to reduced intensity fludarabine and busulfan in a non-randomized phase 2 study. In this study at MD Anderson, 31 patients got the myeloablative flu-bu and 15 patients got reduced intensity flu-bu. And when looking at relapse at 1 year, the incidence of relapse was reduced with myeloablative flu-bu at 20% compared to 53%. And 3-year event-free survival was also improved with the myeloablative conditioning at 50 versus 27%. Unfortunately, there was no significant difference in overall survival between the myeloablative and reduced intensity arm. But this gives us some thought as perhaps myeloablative flu-bu may be a well-tolerated myeloablative selection compared to perhaps more intense myeloablative regimens containing either double alkylators or cyclophosphamide and total body radiation, but more data is of course needed. One significant concern with using intensive conditioning for patients with myelofibrosis is the risk of hepatotoxicity and ultimately either veno-occlusive disease or sinusoidal obstruction syndrome, which has been identified as particularly common in this patient population in a couple of publications now. So to address this high frequency of veno-occlusive disease, the group at the Fred Hutchinson Cancer Center in Seattle studied cyclophosphamide and busulfan conditioning, where they reversed the order of administration of the typically used bu-cy regimen. And they studied this in 51 patients with myeloid malignancies and then compared that to a historical control of 271 patients who received the conventional busulfan and then cyclophosphamide for myeloid malignancies. And they found that giving the cyclophosphamide prior to the busulfan reduced the levels of the hepatotoxic hydroxycyclophosphamide metabolite when measured with area under the curve. And this is thought to translate into a reduced risk of veno-occlusive disease compared to the historical control that received bu-cy. The BuSci arm had 30% of patients develop veno-occlusive disease, and no patients with cyclophosphamide followed by busulfan developed VOD. And importantly, in the patients that had myelofibrosis, there was no difference in relapse at 2 years. However, if you look at the patients with myelodysplastic syndrome or patients with acute myeloid leukemia, those patients in fact did have an increased risk of relapse when Cy was given first, followed by busulfan. So I think we have a signal that, at least in terms of tolerability, cyclophosphamide followed by busulfan may be a good myeloablative regimen for patients with myelofibrosis who can tolerate myeloablative conditioning. The current guidelines that have been released by EBMT and also the British Hematology Group do recommend reserving myeloablative conditioning for patients that have good performance status, that are younger age, typically less than 45 years, but perhaps that could be stretched in patients with exceptional performance status, and of course, patients with limited comorbidities. And because of the average age of myelofibrosis diagnosis being greater than 60, oftentimes we're using reduced intensity conditioning for patients with myelofibrosis. Unfortunately, the guidelines do state that there is no specific regimen recommended because of lack of evidence, and this is an area of unmet need. So for our patients that we think would be most appropriate for reduced intensity conditioning, there are several options available. The first that I'm going to discuss comes from a recent publication from the Mayo Clinic group that did a retrospective comparison of 3 regimens for reduced intensity conditioning. 61 patients were included in the study, and patients received a regimen of fludarabine, carmustine, and melphalan, which they termed FBM, fludarabine busulfan, or fludarabine melphalan, with the primary endpoint being full donor and myeloid chimerism at day 30 and day 100 following transplant. And these endpoints were selected because previous studies have identified these markers of chimerism at day 30 and day 100 to be associated with long-term overall survival benefit. So the regimens that contain the melphalan, both FBM and fludarabine melphalan, were shown to be more likely to achieve full donor lymphoid and myeloid chimerism both at day 30 and day 100 compared to a regimen of fludarabine and busulfan alone. However, unfortunately, there was no significant difference in overall survival at 2 years observed. Importantly, the fludarabine busulfan group had the highest incidence of relapse in the study. Relapse incidence was 29% compared to 9 and 14% for the melphalan containing arms, but this does not reach statistical significance. But I think we have a signal here that perhaps fludarabine busulfan may be a little less active and, of course, less intense for patients with myelofibrosis. Another study is a retrospective study combining patients treated by the groups in Paris and Hamburg that was published in 2016 that looked at fludarabine busulfan with anti-thymocyte globulin and compared to that with fludarabine melphalan in 160 patients. The fludarabine melphalan group was associated with an increased risk of grade 2 through 4 acute graft versus host disease at an incidence of 65 compared to 35%. However, fludarabine busulfan was associated with an increased risk of relapse with a hazard ratio of 9.2. However, at the end of the day, we see that overall survival at 7 years was actually a bit better with the fludarabine busulfan arm, 59% compared to fludarabine melphalan at 52%, which was a trend towards statistical significance. So we see perhaps increased toxicity early on with fludarabine melphalan, but increased risk of relapse with fludarabine and busulfan. I think another recent publication by Schuvel and colleagues deserves mention, a publication of 67 patients transplanted over 15 years that compared a regimen of thiotepa, fludarabine, and busulfan, or TBF, which is an intermediate intensity regimen not defined as myeloablative or reduced intensity, as the preferred conditioning regimen compared to either myeloablative or reduced intensity regimens used at those institutions during that period. And while only 12 patients received TBF, the TBF transplanted patients did have improved progression-free survival at 1 year at 80% compared to the other myeloablative and reduced intensity regimens. So these patients treated with TBF were all in the latest 5-year period and have a median follow-up just over 1 year. So we do need longer follow-up, but I think this regimen could be important to assess in future studies. So at the end of the day, myeloablative conditioning does appear to be associated with improved GVHD-free relapse-free survival, reduced incidence of relapse, and less risk of of graft failure. However, we do see greater toxicity and no significant improvement in overall survival in the available data. Because most of patients with myelofibrosis have advanced age and advanced performance status, we see that those patients are most likely going to need reduced intensity conditioning. And unfortunately, we don't have any data to suggest that one regimen is better than others in terms of overall survival. Fludarabine busulfan does seem to have an increased risk of relapse compared to melphalan-containing regimens, but those may also have an increased risk of toxicity and GVHD. And I think thiotepa, fludarabine, and busulfan, which is an intermediate intensity regimen, appears to be a promising option, but we need a bit more data and longer-term follow-up before many centers consider adopting this regimen. So those are my thoughts on conditioning for myelofibrosis patients. I appreciate you listening.